What do those x-rays, doctor, show? These reveal a well-aligned fracture of the distal ulna involving the radio-ulnar joint with slight shortening, or perhaps 2 millimeters more or less. What about the radius? There is a non-displaced fracture of the ulnar styloid. This is on the antero-posterior view, which I am showing right here. The rest of it reveals no abnormalities at all. Is there a name for this type of fracture, doctor? I try not to use eponyms or names. Well, how did you record the name of the fracture in our records on that date? I record it as a fracture of the distal ulna that's intra-articular, that involves the radio-ulnar joint associated with an ulnar styloid fracture. Doctor, intra-articular refers to the joint, is that correct? That refers to the fracture line extending into the distal joint. And comminuted refers to more than one fracture piece, is that correct? Correct. And would you characterize this as a serious type fracture, doctor? I characterize it as a fracture that needs to be followed. Why is that? Because all these impacted fractures that are put back into place need to be followed. You said that you noted shortening on that x-ray. What part of the body did you notice that there was shortening? If you look at the articulation between the radius and the ulna in the anterior-posterior view, you see slight shortening. What do you mean by shortening, doctor? The surfaces are not perfectly matching. And can, doctor, that be a problem? It may be normal or it may be a problem. And is that, doctor, something you need to be mindful of when you are creating comminuted fractures such as this? Well, I don't create them. Did you perform an examination of Mr. Moran on June 28, 1995? I did. What did that examination consist of, doctor? Whenever you examine a patient, you start off with just eyeing them and seeing them, whether they are in any acute distress, whether they are in severe pain. And I would characterize Mr. Moran as being in mild pain. He was not writhing. He showed what I would expect to be a normal presentation of this pain. Did you say he was not writhing? Yes. Was his hand in the cast? It was in the long arm cast. Did you remove the cast? I did not. Did you perform any kind of manual examination where you had to examine him? Well, the second part of the visit is to touch a patient, or palpate, as we call it. By doing so, you assess how much swelling there is, and in Mr. McNulty's case, he had moderate swelling. What does touching, doctor, tell you? You assess by touching to make sure there is no impingement of the finger motion of the cast, and that's a scouting technique to avoid stiffness of the joint. If a cast is blocking, you must relieve it or make sure that there is no blockage of the proper joint that should be moved. Did you form a plan of treatment at that time for Mr. McNulty, doctor? I did. What was the plan of treatment, doctor? Whenever you see a patient, you don't just treat the x-rays, you treat the patient. I knew he wanted to go back to work. He explained that he was told that he needed surgery, and I tried to explain to him why this did not need surgery at this time. Surgery was always an option at a point where the corpus became surgically untoward. What did you tell him? What I told him is that the fracture should be followed over time. There is a critical 2-week period that I follow in my practice, and during that time you must watch for swelling. You must move the finger to obtain full range of motion, because that oftentimes leads to an abnormal result, even though the fracture may heal, and this is something very important in this 2-way period. Did you discuss with him how long, doctor, the cast would stay on the arm? Defense counsel, objection, hearsay. The court, no, overruled, answer the question. The normal period that I would discuss is 4 to 6 weeks. What do you tell them? I explain to the patients that the time varies according to the patient's age, that his bone density or structure is like and the nature of the fracture. Okay.
It's okay.
$150.